Okay, this presentation is on Chapter 4, Anesthesia from your Understanding Procedure Coding a Work Textbook. So basically when we are talking about anesthesia, that we pretty much means loss of sensation. That's what anesthesia means. And anesthesia is used to help relieve pain. And you can use a variety of methods to do that. Injection, inhalation, and installation. We're going to talk a little bit about those in just a second. And also, when we're looking at the administration of anesthesia, that's done by who we call an anesthesiologist or a certified registered nurse anesthetist. That word gets your tongue tied. Now, there's several types of anesthesia. One is general anesthesia, and your general anesthesia is pretty much the person is not conscious. It alters that patient's perception, so they are totally they have a loss of consciousness, and there are several ways that they administer general anesthesia. And we just spoke about these just a few seconds ago on the slide. You got your injection, and when they do it through injection, they're doing it through your bloodstream. When you're doing inhalation, you're breathing in respiratory, circulatory systems, and then your installation is through a body cavity to a mucous membrane. You also have what we call balanced anesthesia when they're using a combination of the three we just talked about. Excuse me, no topic point there on the slide. I apologize about that. Alright, so that was general anesthesia. You also have what we call regional anesthesia when they are deadening just a particular area or region of the body, and they do that several different ways. You can use blocks, like you have what we call beer blocks, where they're injecting it into the arm below your elbow or in your leg below your knee. You also have an epidural block, and ladies most definitely probably is familiar with epidurals if you had any kids or whatnot, where they are injecting it into that epidural space. You also have another type is local. So we did general, regional, the next type is local, and that basically is like in a small area. Your book says like a finger or a toe. And they tend to apply that topically, or they can inject it subcutaneously. When it comes to coding and billing for anesthesia procedures, what you need to understand is that hospitals do not bill for anesthesia. It's a professional service, so it's going to either be billed through your anesthesiologist or your CRNA if they have an office or what have you. If you think about it, if you have had any exposure or experience with a hospital bill, or someone, your parents, or maybe you have been in a hospital, and if you've had surgery, the anesthesia bill comes separately. That's why multiple bills from a hospital. You say one admission, you get multiple bills. So that anesthesia bill is one of those instances. So your hospital does not report anesthesia codes. Now, if a hospital is billing anesthesia codes, they're billing for an anesthesia office of some sort. So they're doing it for a professional office. The hospital does not bill anesthesia codes. The other thing here, depending on who the payer is, some payers require anesthesia codes and some do not. So you have to pay attention to who you're billing for. Some want you to use the anesthesia code, some require you to use surgery codes and no anesthesia codes. Again, you have to become familiar with the insurance companies that you are dealing with or billing to. So essentially what you can have is you have two different patients and they both have the same procedure, same anesthesia, and you're billing both. and you might bill them differently based on the billing company's rules. All right, so how do we look up your anesthesia code? Basically, you're going to go into your index and look up your main term will be anesthesia. And then from there, you're going to do type of procedure and then the body area, the anatomical area of the procedure. Okay? So, for example, your book gives an example of the Abbey-Estelander procedure. So basically, if I was trying to code for the anesthesia for that procedure, I will go to the main term anesthesia. Then I will look up the term Abbey-Estelander procedure, which is the name of that procedure, and then I'll go to the from there to assign the code. So you go to your index on the anesthesia, then to whatever procedure you're performing, and then to the site of the anatomical site. Another example they give here, like anesthesia vulvectomy for a vulvectomy. So then, what would you look up first? Well, you would go to anesthesia, then you would go to vulvectomy, all right, and get your code that way. Now, there are certain modifiers that you append to your anesthesia code. Your book on page 91 at the bottom gives you a listing for those. You got your modifier 22 for unusual procedure services. You got modifier 23 for unusual anesthesia. You got modifier 32 for mandated services. Modifier 51, multiple procedures. Modifier 53 for discontinued procedure, and modifier 59 for distinct procedural services. These are the modifiers you use with anesthesia code. Your book also gives you a note about being careful about modifier 47, saying that the surgeon who administered that regional or general anesthesia uses this modifier. All right, this is when you will add that modifier to that code. It's not to be used as a modifier for your other anesthesia procedures. Code 00100 through 01999. So we've listed the CPT modifiers we use with our anesthesia code, but you also have your HIM2253 level 2 modifiers that can be used as well. On page 92, they give you a whole bunch of those: your AA, your AD, G8, G9, QK, QS, QX, QY, and QZ. Those are your alphanumeric modifiers. They also brought out the point that depending on your pair, you may or may not use your HIM2253 modifiers with the anesthesia codes. You also have what we call physical status modifiers, which we're going to talk about in just a bit, that you report with anesthesia codes. Medicare does not accept physical status modifiers. We'll get ready to talk about those in just a second. So basically, you have to calculate your reimbursement. When you're calculating that reimbursement amount for your professional anesthesia services, there is a formula to do that. And so we're going to go over each of the terms in the formula so we know where we're pulling this information from. So your formula for calculating your anesthesia charges is basic value plus time units plus modifying units equals total units. Then once you get your total units, you're going to multiply that by your conversion factor, and that's going to give you the total fee. So let's look at each of these terms in the formula. So we had the basic value was the first term mentioned in that formula, and basically each of your anesthesia codes has a basic value attached to it. This is not something you have to come up with, but it is published by your American Society of Anesthesiologists, your ASA. They publish those on a regular basis, and they update them, and we have a table in which we pull that value that they're assigning to each of those anesthesia codes. There are two elements that make up your basic value. and basically that's your usual services and your value of the work. So what are we talking about when we say usual services? We're talking about all those services that are going to be a part of that code, are included in that code. That will be your pre-op visits, your intra-op care, and your post-op visits. So basically, when something is bundled into that code, this pretty much means that you're not going to code that separately. That will be inappropriate to do that if it's bundled into that anesthesia code. So those things are what we call usual services, and it's listed there. If you read there on page 93, what things are included under intra-op. It says, for example, administration of fluids, blood products, monitoring vitals, those types of things. And you have notations in your code book telling you what's included. So those things, and usually when you get ready to have surgery, you probably go into have a history and exam performed by your anesthesiology staff. That's in your pre-op visit. So these things are bundled into, and they are called your usual services. Now, if there are things that are performed or services that are provided that are beyond the scope of these services that are bundled, then those services will be reported separately or in addition to your basic anesthesia service code. So this all flows into usual services, which is part of what they're looking at, part of your component of your basic value. The other second element that they're looking at is your value of work. Basically, what it costs for them to do that anesthesia service. So those are your two components. Again, the value is published through your American Society of Anesthesiologists, ASA, so you are not having to come up with it. You just once you know your code, you look up that code in the table, and it's going to give you your basic value unit. All right, so in our calculation, our formula, it was basic value plus time units. That was the second element of the formula. And basically, your time unit represents the actual time that was spent providing the anesthesia service. Now, they do it in units. Your most common increment or unit is 15 minutes. However, there could be different other increments based on what your insurance company requires. They say 30 minutes is another increment you may see. And your time starts when that provider is in personal attendance to prepare that patient for that anesthesia, and it ends when that provider is no longer in attendance and that patient can be sent to post-surgery recovery area. So that's the time that they are actually counting between those two inputs. Now, your modifying unit is determined by physical conditions and qualifying circumstances that affect your administration of your anesthesia. When we're looking at your qualifying circumstances, basically we're talking about conditions that are out of the ordinary that's going to impact the administration of the anesthesia. If you look at table 4.1 on page 94, it gives you some examples of qualifying circumstances. For example, 99100 is anesthesia for a patient of extreme age, less than 1 year old and greater than 70 years old. And they assign a unit of 1 to that code. The other thing you need to know about these codes, these are add-on codes in table 4.1. So you will see a plus sign beside these codes in your coding manual. So that means you cannot code these separately. It has to be in addition to your anesthesia code. You also see the unit there that's assigned. This is what you're going to plug in into that formula when you get your total units. And we'll talk about that in just a second. So one part of your modifying unit is the qualifying circumstance, meaning conditions that are out of the ordinary and that will impact the administration of anesthesia. So when somebody is extremely old or extremely young, that's going to impact administration of anesthesia. Now, the other factor for your modifying unit is your physical status modifier, which I mentioned a few seconds ago. and your physical status modifiers describe the patient's health status. All right. And so if you look at table 4.2 on page 94, you see your physical status modifiers, P1 through P6. So P1 will be your normal, healthy patient. P6 is a declared brain dead patient whose organs are being removed for donor purposes. So there's two extremes there. If you look over there into your right-hand column, you see units assigned to your physical status modifiers. Normal healthy patient is 0. That brain dead patient, P6, is 0. P5 has 3, so forth. So that's going to be the unit you'll plug in into the formula. Again, this is looking at the patient's health status. That's what your physical status modifier is. Now, the qualifying circumstance code and your physical status modifier, Medicare does not recognize these. Does not say that another insurance company won't, but Medicare does not. So, looking back at that formula, what you have to do is you're going to take basic value, you're going to look it up in the table that's published by the ASA. It's going to have a unit assigned to it, a value, just like we saw in your table 4.1, table 4.2. You're going to plug that in. Then you get your time units depending on what that is. So, for example, if you, in your documentation, it says that it took a total of 1 hour to complete those services, and the time unit is going to be in 15-minute increments, then you're going to plug in 4. Because it's 4 15-minute increments in an hour, right? So you will get your basic value units, plug that in the basic value. Time units, plug that in. Then when you get the modifying units, you're looking at both table 4.1 and table 4.2, your qualifying circumstance, your physical status modifier. Depending on what you're choosing here, say if it was 99100, you're going to add the 1. And say maybe it's a P3 in terms of physical status modifier, you're going to add 1. So that will be 2 that you will plug into modifying units. So let's say our basic value is 3, our time units is 4, and our modifying units is 2. Then you're going to add those all together, and you're going to get your total units. Okay? So hopefully that makes sense. So once you get your total unit, you're going to multiply that by what we call a conversion factor. And basically, your conversion factor is based on your geographical region. And what this does is convert those total units into a dollar amount. So there's a table for your conversion factors as well. Your book gives you that. It's at a CMS website. You access the table. We'll look at that when we do practice. But you're going to get whatever that conversion factor is, multiplied by whatever you added up in terms of your total unit, and then that's going to give you, and those conversion factors are in dollars, so that's going to give you your total amount, total reimbursement amount. Now, the other couple of things was a couple more, 2 more concepts that they discussed in chapter 4. One of those being about your moderate conscious sedation. And basically with that, this is where they sedate you, but you are still able to respond to some stimulation. So you're not totally unconscious like general anesthesia. And basically, your moderate or conscious sedation is reported using anesthesia codes from the section 00100 through 01999. All right. If the physician performing the procedure is not the physician administering the sedation. So this is what they're telling you about your moderate conscious sedation. The codes for moderate conscious sedation range from 99143 to 99150, and age and time are determining factors. So that's your note that they're giving you on your moderate conscious sedation. The other last thing that they talk about, that they point your attention to is that the surgeon and the anesthesiologist bill separately, but their charges have to mirror one another. So basically, if the anesthesiologist is providing anesthesia for the same surgery that surgeon is doing, then you're going to have the same diagnosis and the same procedure code should be reported by the anesthesiologist and the surgeon. Okay? Your book actually says the same diagnosis and the same procedure code should be reported if the payer requires the anesthesiologist to submit the surgery code in place of the anesthesia code. If an anesthesia code is submitted by anesthesia staff, it should reflect the same procedure submitted by the surgeon. So that's just a little area you have to pay note of when